this is I've given you in the back. If you go past the antibiotic Jeopardy part, I've given you the answers to these, so you don't have to spend so much time jotting everything down that I say, because I know it's a lot of information here. And this is kind of just free flow anyway. So I want to make sure you get the right answer in your handout, and so we don't have to spend a lot of time just going over things again and again. This is mainly going to be, what I want to do is just kind of present a bacteria to you, and then I want you to think what would be the best antibiotic to use against that bacteria. Okay, so we'll just kind of run through some of these in the last 30 minutes. So category is penicillin here. You form your answer in the form of a question, and for $100, what antibiotic is used for strep pyogenes? So what do y'all think? Okay, so first thing is on the boards is they don't say group A strep. They'll say strep pyogenes. So I want you to, some old gray-haired person says they need to know strep pyogenes. Okay, it's like, okay. So just know it's group A strep. So how do we treat group A strep? Okay, penicillin, right? So just look for penicillin. Look for penicillin, PenVK, ampicillin. Okay, just look for that. All right. They may give you, try to get all fancy on you too and go, well, this organism has a penicillinase resistance. And all they're telling you is this is Staph aureus. This is methicillin-sensitive Staph aureus, okay? So before, when we first came out with penicillin, it killed staph just fine. And then the organism got smart and developed a penicillinase, which pretty much, caused the penicillin not to work. And so it's Staph aureus now. So regular old methicillin-sensitive Staph aureus produces this penicillinase. So what's the best penicillin, IV penicillin, to use against that? Okay, nafcillin or oxacillin. Okay, so look for nafcillin or oxacillin on the test for that. Okay, and then the gram negatives came on, and they said, well, we're tired of penicillin too. We'll fix it. So they made a beta-lactamase. Okay, and so there's 3 different drugs that are available. Okay, there's Zosyn, right? There's Timentin, and then there's Unison. Okay, and all 3 of those are just, what it is like Zosyn is piperacillin, tazobactam, and Timentin is ticarcillin, clavulanic, and then Unison is ampicillin, sulbactam. And that sulbactam, that tazobactam, and that clavulanic added on is just a beta-lactamase inhibitor. Okay, so the drug company got smart, said, okay, we'll just add this inhibitor with this antibiotic that used to work, and it'll work just great. So adding that inhibitor, what it does is it improves your gram-negative coverage really a lot, but also gives you anaerobic coverage too. Okay, so Unison, Zosyn, Timentin, they all have good anaerobe coverage. Okay, and remember, Zosyn has really good Pseudomonas coverage. Okay, that's the one claim to fame for it. Okay, the oral penicillin effective for Pseudomonas. So, they give you the kid who stepped on the nail and it went through the tennis shoe, and and you're worried about Pseudomonas cellulitis, or they have a cellulitis and you think it's Pseudomonas, and they give you all these choices of penicillins, oral penicillins, because the kid's not that sick and it's just it's a little cellulitis. So don't put Augmentin, okay? And that's what most people, you need to use something else, okay? Remember, the oral penicillins don't cover, Augmentin does not cover Pseudomonas. Okay, Augmentin does not cover Pseudomonas. Right? So there's really no oral drug here except for a quinolone. So if they're older than 18, you're fine. But if they're younger than 18, you're kind of stuck. Okay, you're going to have to use something IV like Zosyn, or you can potentially talk to if it's a 16-year-old, talk to parents about the risk-benefit of Cipro in a 16-year-old. All right, how much do you want to wager? All of it? Of course you do. All right. So it's on computer, so they may have you draw something. I'm just teasing. They're not going to make you draw anything on the computer with a mouse. So just some of you are freaking out, like, oh, I don't remember it. I want to remember it now. Well, there it is. Don't worry. Don't memorize this, please. All right. But they're more likely to ask you this. What's the best and cheapest aminopenicillin for Enterococcus? So what do we use for Enterococcus? Okay, ampicillin, right? Ampicillin. So remember, in the babies, that are less than 3 months of age, and we always make sure we have ampicillin on board because it's going to cover Enterococcus and it's going to cover Listeria. Okay. All right, I'll give you this list, just the things that penicillin are still good for. So you can kind of go through this when you get back home. Again, that was so that you've got this. All right, so weird infections. So they're going to throw some things that maybe we talked about them, and you've forgotten, or maybe they just put something on there. So, so the best treatment for tularemia. Okay, and the kids, let's say the kid's not that sick. Okay, generally, if you don't know, just pick doxycycline. Okay, so doxycycline is always a good choice. Now, if the kid's sick, you want to look for streptomycin or gentamicin is what they might give you. But if the kid's not that ill, doxycycline. Best treatment for Q fever, doxycycline. Okay, you see the pattern here. What's the organism for Q fever? Coxiella burnetii. Okay, they may just ask you that. I mean, sometimes they ask you just crazy things. Best treatment for Ehrlichia. Good. See, you're getting it. Okay. All right. And how this presents from a tick bite, and what does it do to the cells in the blood? They're all low, right? You get pancytopenia with Ehrlichia. Okay. Best treatment for Rocky Mountain, doxycycline. Someone asked me yesterday, which is a good question. You know, what do I do about the 6-year-old with Rocky Mountain spotted fever? Do I use, you know, am I worried about using doxy? Well, you're worried about it, but the problem is you can't get chloramphenicol anymore anyway. So, you know, if the test had it as a choice, I guess you could pick it, but it's not really readily available. And really, a short course of doxy that you're going to use for these type diseases isn't going to cause any problem. So most people are pretty comfortable using them for short course in children because it is better. And chloramphenicol, you just can't get anymore. All right, we didn't talk about this. So best treatment for this, what is this? What is Bordetella? Okay, pertussis, right? Okay. So azithromycin, most people have gone to using azithromycin for this. They could give you erythromycin still. Okay. All right, a patient with a UTI. So here's where they give you a kind of a little scenario, and let's say this is a 6-year-old girl. Okay, so what might be a good choice? Okay, Bactrim. Yeah, I mean, Bactrim would be fine. You could use a cephalosporin, you know, one of the cephalosporins maybe if you wanted to, if she was sulfa allergic, you know. So there's a lot of choices. If she's sick and she has to go in the hospital, what would be a good choice? Okay, like ceftriaxone would work, or clafuran would be good. So clafuran, 3rd-generation cephalosporin. I mean, the other thing is when you're trying to figure out what to do, what's the most common organism here? Okay, E. coli, right? So you just need to think of an antibiotic that's going to get E. coli, right? So just think about that. Now, let's say it's a 1-month-old. Okay, so what other organisms do we throw in here now? Okay, so Enterococcus, again, remember we need to be worried about that, right? So what antibiotic might we add to our clafuran? Ampicillin? Okay, good. Okay, an infected central line. So the first thing is, what do you think, what's the most likely organism going to be? Staph. And what kind of staph? MRSA or MRSE, right? So methicillin-resistant staph, epi, or methicillin-resistant staph aureus. Because they're obviously, if they got a line, that means they've been in around hospitals, okay? So they're likely to have resistant organism. So what's the best treatment for MRSA or MRSE? Vancomycin, right. If they had a fungus in here, what would you need to do to the central line? Take it out. Good. All right. Okay, endocarditis in a 16-year-old drug addict. All right, so here you got to think about what's the hardest thing I have to treat. Okay, so what's the most likely hardest thing you think? Like staph, right? So staph aureus, particularly MRSA. So you're probably going to need like vancomycin. You probably want to start with vancomycin. And then the other thing is you've got to worry about Pseudomonas in this group. Okay, so you might start them on aminoglycoside maybe, or you might start them on Zosyn or something really broad spectrum. But you're going to need really, really broad coverage for this kid because he's exposed to a lot of resistant organisms. So Vanc and Gent, you know, you might use as a choice here. Okay, meningitis. Let's make it a 14-year-old. 14-year-old kid with meningitis. What's your empiric therapy going to be? Okay, Vanc and ceftriaxone. okay? Vanc and ceftriaxone. All right, what if we make it a, this is tricky, let's make it a 2-month-old. So they've been home in the community for 2 months. So what do you want to use? Many people would use three drugs here. So they use Vanc and ceftriaxone because the kid's been exposed to pneumococcus in the community now for a while. And then you would still probably use the ampicillin. So you might use AMP, Vanc, and ceftriaxone in the 2-month-old. Okay. All right. So what do you want to? What are you worried about in this patient? What are you worried about in this patient? So neutropenic patient, gram-negative. Which gram-negative are you worried about? Pseudomonas. Okay. So what's a good choice here? Okay, Zosyn. Zosyn would be good. Maxapine, cefapime. Okay, do not pick ceftriaxone, right? Ceftriaxone, Rocephin does not cover Pseudomonas. Okay, you're not going to pick that. Okay. This you may or may not know. This is imipenem. Okay, imipenem, Primaxin, imipenem. Mainly we see it in you be careful. You want to be careful in using it in kids with renal insufficiency. Okay, so if they've got renal insufficiency, they have a higher risk of having seizures with this drug. Okay, what does this? Rocephin. And that's part of the reason why there's some concern, or there's concern about using ceftriaxone in younger kids less than 2 months of age, is because of the biliary or bilirubin problem with it. It's probably more theoretical than real, but many times we steer away from using ceftriaxone in that age group just because of that concern. But it can cause some problems with the gallbladder occasionally. Okay, so classic thing they'll ask you about with amphotericin B. So what are the 2 electrolytes you worry about? Okay, potassium and magnesium. Good. Potassium and magnesium. Okay, so they tell you the nurse calls you and says that this kid is just all red now. Okay, so what do you think caused it? What antibiotic? So vancomycin. And the mechanism is if you infuse vanc too rapidly, okay, it causes mast cells to release histamine. So they turn red. So all you have to do is slow down the infusion and give them Benadryl, diphenhydramine. Now, the key thing here is the nurse calls and says, well, do I need to put in the chart they're allergic to vancomycin? And the answer is no, okay? So it's not an allergic reaction, okay? It's a reaction to the antibiotic being infused too rapidly. So you just slow it down, give them some diphenhydramine, they're fine. Okay, this macrolide can cause significant hearing loss. Okay, erythromycin, and one reason we kind of forgot about it until we had that cases of Legionella were appearing in some older kids, and Legionella, and you were having to use high dose of erythromycin, like 1,000 milligrams, Q whatever, and they would have hearing loss. Okay, usually it's reversible, but just keep in the back of your mind that it can cause hearing loss. All right, so this is my point with this question is you're going to remember a lot of really stupid things, okay, and a lot of facts when you get back home. And this will be one, but you'll also remember things that actually be on the test, I promise you. So how many people remember which toes? Fourth, okay, see? So this is how good you are. See, your short-term memory is it's stretched now. We're almost 18 hours almost, and you still remember something. So that's good. But the point is that, if you can associate some of these things that you have trouble remembering with something silly or something in your mind to remember it, it makes it easier to remember. So if you can associate some of these things that you have to remember with something that, is easy or funny, then it helps sometimes. Okay, they might still ask this, what binds to the 50S ribosomal subunit of the bacterium? This is classic PEDS board's nightmare question, right? Pharmacology. So this is erythromycin, okay, erythromycin. Okay, so how do you treat Lyme disease in a patient with third-degree heart block? Okay, the cardiologists are going, you put a pacer in, okay, which is right, and what do you treat them with antibiotic-wise? Ceftriaxone, okay, ceftriaxone. So remember with Lyme, so meningitis, carditis, you're going to use ceftriaxone, and then pretty much everything else you can use doxycycline or amoxicillin. Okay, if you see this aminoglycoside on the test, you know the patient has cystic fibrosis. Okay, if you see them using this antibiotic on the test, you know the patient's got cystic fibrosis. So tobramycin, okay, it's the only time we use it. Tobramycin in general is a cystic kid. And the reason is we really know the pharmacokinetics with Tobra in cystic kids, and it works really, really well against Pseudomonas. Okay, so tobramycin. Okay, how good is your Pfizer rep? All right, so remember azithromycin. Okay. Okay, there's just an iguana sitting there. So what organism are you worried about? Salmonella, good. Okay. Okay, organism found in a cat's mouth that is not a normal human inhabitant. Okay, so Bartonella or Pasteurella, right? So most common thing in a cat bite, Pasteurella. Okay, most common thing in cat scratch disease, or the cause of cat scratch disease, Bartonella. Okay, don't get those confused because they may have them both in the question. Okay, organism responsible for visceral larva migrans. Mumbling, mumbling. Toxocara. Toxocara, remember that was the cat flea, the flea jumping from the little kid, or from the cat into the kid's mouth. All right, can cause a pseudoappendicitis. Okay, good. Yersinia pseudotuberculosis, okay, or Yersinia pseudoappendicitis, Yersinia enterocolitica. Okay, how much you want to wager? Good, go for it. So viral meningoencephalitis occurring after exposure to this animal. Okay, y'all remember? Lymphocytic choriomeningitis. meningitis. Okay, lymphocytic choriomeningitis. meningitis. Okay, some other weird infections they could throw at you. So pneumocystis pneumonia. Okay, so here, if doxycycline's not there, then the other choice to look for is Bactrim. Okay, so trimethoprim sulfa. So, right, trimethoprim sulfa, good. And then what if they say that the kid's hypoxic? What do you want to add to that? Steroids. Okay, good. Okay, mycoplasma. Okay, doxycycline, right? Doxycycline works good for it. Erythromycin, azithromycin, any of those work well. All right, C. difficile toxin-induced diarrhea. Okay, let's say the kid has a white count of 20,000. So what do you want to do? Okay, good. Vancomycin. Remember, the guidelines change so that if the child is sicker, you want to start with vanc first instead of metronidazole. If they're not that ill, use metronidazole. And then for your recurrence, what do you want to use? Same thing. So whatever you use the first time, just use it again the second time. Okay, how do we treat listeria? Okay, ampicillin, and then you would add aminoglycoside too initially. It's Ampingent. Chlamydia pneumonia. How do we treat that? Doxycycline. Okay, there's this weird, this name here you don't recognize. Just pick doxycycline. Okay, erythromycin, azithromycin works. Okay, who sang the song Cat Scratch Fever? Ted Nugent. Good. All right. Okay, this effect occurs with aminoglycosides against gram-negative bacteria in which bacterial growth is suppressed for a period of time after the level of the drug falls below the MIC of the bacterium being treated. It's a classic PEDS board question where they'll give you some definition of something and then say, what is this? Okay, and this is the post-antibiotic effect. Okay, and in simple terms, what it means is if you give an aminoglycoside, which many of you are using once daily aminoglycosides, this is why once daily aminoglycosides works really well. Okay, it's because you give the aminoglycoside, and what happens is it kills the bacteria really well. The MIC is way above the MIC. Okay, but then the amount of gentamicin in the bloodstream drops, but it drops below the MIC for the bacteria. But with the aminoglycosides, it still keeps killing the bacteria. Okay? So even though it's below the MIC for the bacteria, it'll continue to kill that bacteria. So it's called the post-antibiotic effect. So the nice thing about it is you can give once daily, you reduce the risk of renal insufficiency. All right? So the post-antibiotic effect. Okay, this is just a pet peeve. I'll turn it in every year to the boards. They haven't done it yet, but they might. It's gentamicin. So if you've been writing gentamicin with a Y all your life, you've been doing it wrong. So anyway. Okay, you swim in a pond with 12 dogs. You develop an infection from a spirochete. What antibiotic you want to treat, use to treat? Okay, so there's a couple things here. So a spirochete. So you can kind of use your brain a little bit here. So what's the most common spirochete that you treat? Syphilis. Okay, so what do we use to treat syphilis? Penicillin. That would work fine here. What else do we use to treat syphilis with? Doxycycline, okay, if they're penallergic. So, doxy is most likely what they'll give you, but penicillin would be okay too, all right? The two adverse effects with aminoglycosides. Okay, remember hearing and kidney. It's always good if you don't have a clue and they've got something going on. It's the kidney and the ears are always together. Okay, remember there's that Alport syndrome and there's all these weird things, and it's always the kidneys and the ears that go together. Okay, so osteomyelitis. What do we say is the most common osteomyelitis cause osteomyelitis? Staph aureus. Okay, so you're thinking, okay, I'm looking for oxacillin or I'm looking for vancomycin in the question choices, all right? And they don't have that there. Because what they likely will give you is this antibiotic because the cephalosporins, as you know, particularly this one, is very cheap, and we only do it 3 times a day. Okay, so if it's methicillin-sensitive Staph aureus, look for cephalexin, okay, Keflex. I'm sorry, cefazolin. Cefazolin is IV form. So cefazolin is what you want to look for. First generation. So Keflex. I'm sorry. Ancef. I keep getting, I'm having a TIA today. All right. So cefazolin. Okay. On the test, so they give you a kid with Enterococcus, Listeria, or MRSA. And this last one's changed a little bit, but they have all these cephalosporins listed, right? They have all these cephalosporins, okay? And you just need to know, like particularly the one they will give you every single time and say, don't you want to use ceftriaxone? And you don't, because it doesn't get this, right? All right, so ceftriaxone does not cover everything in the world. So, and it doesn't cover Enterococcus, Listeria, or MRSA. There's a new cephalosporin, but it's not approved for kids, so you don't have to worry about it. All right, that does cover MRSA. So you don't have, you're home free. You don't have to worry about it. A patient allergic to penicillin is likely to be allergic to cephalosporins by this percentage. So this comes up on the test. Is what they'll do is they'll say, Johnny had this rash 5 years ago, and now you need to treat his meningitis with, he has rash to penicillin, ampicillin, and now you need to treat him with ceftriaxone. And they say, well, can you do it or not? And what do you think? Yes. Okay. The real risk is about, it keeps shrinking each year, like to 6 or 7%. Now, if Johnny had anaphylaxis to penicillin, okay, I'm not going to probably want to use the cephalosporin. I'm not going to chance anaphylaxis. But, the classic he had a little rash to penicillin, you're not going to worry about that on the test. You're going to use cephalosporins. Okay, agents good for Pseudomonas in the cephalosporin class. So how many people want to use ceftriaxone? No, please don't do that on the test, okay? All right, so cefepime, maxipine, okay? Fortaz, ceftazidime, although there's been resistance with that, so maxipine is probably the one they'll give you, okay? Maxipine, cefepime. Okay, your daily double. So the methylthiotetrazole side chain impairs recycling of vitamin K and can cause hypoprothrombemia in these 5 antibiotics. Name 2. Well, I'll give you them because I can't pronounce them anymore. And half of these aren't available anymore. The deal about this is you've got, generally these are, if you look at the drugs, most of these are used by the surgeons, right? And so the story is they'll give you this 15 or 16-year-old, and the kid's got some underlying nutritional deficit going on, and they're vitamin K deficient already. And you use one of these antibiotics here, and what it does is it impairs the recycling of vitamin K. And so the patient becomes even more vitamin K deficient, and they say he's oozing from his lines. Okay, so he's bleeding from his lines. All right, and it's these kind of antibiotics that do it. So cephalosporins is probably the big one still that they might give you. So it's usually on the surgery floor, and they're calling you as a pediatrician to come figure out what's going on with this kid. The other thing is you need to know with any antibiotic for long term can impair the gut as far as the recycling of vitamin K. So someone can become vitamin K deficient with that as well. Okay, so quick no-nos here. So guess what the answer is? No. All right. So theophylline and Cipro, so here let's say you have this older asthmatic who's on theophylline for whatever strange reason still, and is 18 or 19, and then he gets the UTI, and someone puts him on Cipro. You don't want to do that because you're going to get theophylline toxic. So you don't use these two together. Okay, Cipro, they might try to get you to use an 18 or 19-year-old kid for pneumonia. Know that we never do that anymore. So you need to one of the newer drugs like Levaquin for like a 19-year-old with pneumonia. Ketoconazole, H2 blockers, no. Keto and as well as Sporanox, itraconazole we talked about yesterday. Remember, you need an acid environment for it to be absorbed. And then IV Cipro, again, I don't think they'll ask you too much about quinolones, but if they do, this might be one. Remember, oral quinolone gives you just as good as IV as far as levels. And then Astrinam, if they have it on the test, it's just usually there. Just know that it only gets gram negatives. Okay, it's kind of a weird antibiotic they may throw on you. Some of you never use it. Some of you use it all the time, depending on what your hospital can afford or what their contract is. So occasionally they'll have that. All right, your last question here. Ready to wager all your money? I know y'all can get this one. No. Okay, so what is this? Pinworms, good. All right, here's the eggs. Here's the Scotch tape thing. And then how do you treat that? And that's a fancy name. Okay, mebendazole, but remember, mebendazole is gone now, Vermox, so albendazole is probably what they might give you, although the board still might give you mebendazole because everything's available on the board still. So we're done with ID. All right.